Thank you for joining. This is the February 25th webinar of Connecticut's SustiNet Healthcare Workforce Task Force. I'm Ellen Andrews and I co-chair the task force with Dr. David Henderson. Today we're hearing from the Department of Public Health about their healthcare workforce programs. First, we'll hear from Kristen Sullivan, who's the chief of the Planning and Workforce Development section, about the public health workforce. Next, we'll hear from Jennifer Philippone, chief of the Practitioner Licensing and Investigations section, about J-1 visas and online licensure. And then lastly, we'll hear from Joanna Davis, epidemiologist in the Primary Care and Prevention section, about the National Health Services Corps. A little housekeeping. If you're listening on the phone, remember to input the audio pin that should be visible on your screen into your phone if you want to be able to talk and ask questions. If you're listening on a headset directly through the computer, you don't need that audio pin. We'll be keeping everyone on mute until all the speakers are finished with their presentations, and then we'll have some time for questions. To ask a question, you can raise your hand by pressing that button, but to save time and be sure you don't forget them, you can also type your questions into the question pane text box on your screen at any point in the webinar. The slides and a video of this webinar will be posted online soon on our webinars page at the Connecticut Health Policy Project. So I will let Kristen get started.
Okay, today I thought what I would cover is to define the public health workforce and identify some public health worker shortage areas, and also to identify public health workforce issues and needs. And before I get there, I thought it would be good if I just went over what public health is for those that might not be clear. If you want to go to the next slide, Ellen. I thought by starting off showing the difference between public health versus health care. If we look at public health, we are looking at the health of the population versus individual health. That's what health care takes a look at. We look at the health of the community, whereas health care looks at the best outcome for the individual. We have a focus on prevention, and we have a focus on treatment. And our diagnostic tools are the demographics, vital statistics, and epidemiology. The diagnostic tools for healthcare are thermometer, stethoscope, individual data, and the medical history. So you get the picture there. There's a little bit of a difference. We focus on the population. One thing I do want to say about that is I don't like putting public health versus healthcare up there. I did want to show the difference, but I really think when we're talking about healthcare reform that we have to think about public health and healthcare on the same continuum from prevention, screening, diagnosis, treatment, all the way to the end-of-life care. And I think that's the context that we need to show here when we're talking about healthcare reform. So if we go to the next slide, which is fundamental obligations, this is what public health does. We prevent epidemics, we protect against environmental hazards, prevent injuries, promote and encourage health behaviors, respond to disasters, and assure the quality and accessibility of health services. And you're going to hear from Jen and Johanna a little bit more about that area when they talk about their programs. They really key in on that. If you want to go to the next slide. And the way we meet those obligations is by providing the 10 essential public health services. The best way I can give you a description of how we do this is to go with an example, I think. And if we take something like tobacco, we can start with number one, monitor health status to identify health problems. What are the 3 leading causes of death? Cardiovascular disease, stroke, and cancer. And we know that from diagnosing and investigating those problems, we know that tobacco is one of the leading causes of those types of diseases. So we would have public health education campaigns about the dangers of tobacco. We would get partnerships together to pull together a plan and some policies like the tobacco control plan that we have. We would enforce laws and regulations, which could be no smoking outside of restaurants, teens can't purchase cigarettes, no smoking on school grounds, things like that. link people to needed personal health care services. That could be the QUIT line that we have. And then assure a competent public health and personal health care workforce. We would ensure that our primary care clinicians have that information about the behavioral risks of tobacco use and control. And then, down from there. But that's an example of how we use the 10 essential services to meet our fundamental obligations and to address a health issue. At the bottom there, I do want to note, I put a link in there, and if you do have time, go to that. It's from the American Public Health Association. It is the best short clip video about what public health is. It's very catchy. We use it with our teens. We use it with teachers that we also reach out to talk to them about public health concepts and public health careers, and it's a very catchy video, so just bring that to your attention. Later on, when Jen and Johanna talk, you're going to hear them address, with the programs they have, 6, 7, and 8, enforce laws, link people to needed personal health services, and assure a competent public health and personal health care workforce, and that's really what they do with those programs that they have. Okay, next slide. When we're talking about meeting the fundamental obligations, I thought it was pertinent to add in some of the emerging public health issues to kind of give context to our future discussion about the public health workforce, because these are some of the issues that we have to address. And we're constantly faced with emerging public health issues, but they run the gamut, and they're very complex. And we need a workforce that can adapt or either acquire new skills that are needed to deal with the emerging public health issues. But you can see they do run the gamut here. And those are just some of them. Next slide. Because they're so complex, we need to work with all our different systems and our partners. And you can see here, in order for us to solve some of those problems, or at least start to mobilize and to look at these problems, we have to work with almost everyone: mass transit, parks, defense, managed care, schools, civic groups, all kinds of things. I think the one that's not on here would be the probably the media that should be on here that we need to work with a little bit more. But so next slide. So in that context, I want to start looking at the public health workforce. And this is from census data. On the federal level, they've done a couple workforce enumerations, one in 1980 and one in 2000. And this one is from 2000. And you can see where they've tried to identify the public health workforce, and they define it by all those responsible for providing the essential services of public health, regardless of the organization in which they work. So it clearly isn't just governmental public health sector here, state and local. This is if you provide a public health, one of the 10 essential services, you're incorporated into the public health workforce, and that's how they're defining it. And that's why it's so broad. What I did with the red boxes is I identified a lot of the job classifications that we might hire here at a state public health agency. And you can turn the slide now. If you want to click and bring up the first. There you go. If we look at Connecticut-specific data, this is also from census data, but it's the Connecticut portion of it. And this is an analysis that was done in 2008 from the University of Connecticut AHAC program. And they, once again, used the census data. But, you can clearly see here that from 2000 to 2006, we are losing some capacity in the state and local workforce. You want to click again and bring up the... And here, when we look at state and local public health full-time equivalents per 10,000 population, you can see that the national average is about 14.67, and ours is quite a bit lower, 9.66. So our capacity really isn't at the national average there. If you want to click there again. This is our state public health workforce. Now, this data we have from the DPH personnel office. So we've gone over two different sources of data. One is the census data. The second one is the state personnel office that would collect data on the state public health employees. And you can see here we have about 787.5 full-time equivalent employees. And I can tell you, I didn't want to put this up as a comparison because it needs a little bit more analysis. But when we did this in 2008 and we looked at full-time equivalents, we had about 851. So we're clearly down in our capacity. We didn't lose anything in the leaders and administrators, but that's largely because we've bumped people up into those positions. But we did lose some through the retirements. And that this is largely a function of losing some of that capacity through the recent retirement incentive program. Do you want to click again? Some of the personnel statistics that we take a look at is the average age of our workforce, which is about 47 years old. And this is true across the board. Even if we look nationally, public health tends to have a much older workforce. And it's typically because there's no straight line into a public health profession. It's getting better, but when you go to high school, your guidance counselor doesn't come to you and talk about careers in public health yet. We're working on that. You don't go right into an undergraduate public health program unless you're smart about all that and someone's guided you through that. There's not that many, nationally. So it's been hard. People come in later in life. They get other degrees, and they come into public health. Now, some of that gives the public health workforce a strength because we have people with all kinds of backgrounds working on problems. So it's a strength and it's a weakness, I guess. Our average years of service is 12. That's been relatively stable. Average age of new hires, 35, relatively stable. And then eligible for retirement within 2 years, we have about 26% of our workforce. Before the retirement incentive program, that was about 33%. You want to turn the slide? If we look at the local public health workforce, now we look at both of the governmental sectors. And when we look at the local public health workforce, we have a data source, which is the local health annual report data that they send into DPH each year. So this is from the 2008 local health data report. What I want to show you is the kind of classifications that are hired on the local level. They're a little bit different from the state level, but not too much, just so you can get a sense of who is in that workforce. We did an analysis of the FTEs from last year, and it was around 1,400, and this is showing 900. So that looks like a really big decrease, but it's simply raw data, which is why I want to caution people about using this. It's simply raw data that the health local health departments have reported, and it really needs a little bit more analysis. Sometimes the definitions change and things like that, so just keep that in mind when you're looking at these numbers. But clearly, we're all feeling, and the data is showing a bit of a downward trend in terms of our capacity of the public health workforce. If you want to click to the next slide. These are some of our shortage areas. This is another source of data. We get a lot of anecdotal data. We get anecdotal data about shortages, about where we're having trouble hiring, and into what classifications. But in 2007, ASTO, that's the Association of State and Territorial Health Officers, did a survey of all the state agencies, and this is really what came out. And you can see our shortage areas. They're, really our key key types of disciplines within the public health workforce: our public health nurses, our EPIs, our environmental health practitioners, our lab scientists, and our public health physicians. Planners and the public health leaders, I think the planning capacity is very important, and it's not quite where it was 5, 6, 7 years ago. So I want to mention that. And with the public health leaders as well, we're all talking about graying of the workforce, and you see our average age, and it's especially noted on the local level with the governor's recent report to the governor's office from the local health council that cited that there were some issues coming up with the age of the local health directors and having to replace leadership in those areas as well. I'm going to turn to the next page. Next slide. So just to kind of wrap up, what are some of our workforce issues? We see that we have an insufficient number of workers in specific occupational categories. We have an aging of the workforce and loss of talent through retirement and attrition. Inadequate replacements in the pipeline, insufficiently prepared workers, and then new skills and expectations post 9/11. And with public health preparedness and public health being a part of the response of all hazards, it's really put a lot of strain on the workforce. It's been a new set of skills and new partnerships that we've had to work with. You can go to the next slide. Some of the recruitment and the retention issues that we face, I mean, there's no doubt about it, and you're in the governmental sector, it's just slow going if you're trying to get someone into those positions. Rigid job classifications. You saw all the emerging health issues. We either need to get qualified people to help address those or raise the skill level here in a timely way, and it's hard to do that with the rigid job classifications now. We are subject to hiring freezes, budget crisis, and there is a lack of visibility and understanding about the importance of public health careers that we're trying to work on as well. Lack of career ladders and competitive salaries from the government to the private sector as well. Those all inhibit our ability to recruit and retain what we feel is a capable workforce. If you want to move to the next slide. So looking forward to needs, I would have to say that the biggest need that we have is really, and this is really something from the federal level down, but really resources to support the public health workforce research and policy. And it's because we have that lack of data and the minimum data sets that we all should be collecting. It should really be coming top down. Puts pressure on the states to develop their own. But we really do need to start doing a periodic enumeration of the public health workforce. And what that means is to identify, at least measuring and monitoring the size, identity, and the composition of the workforce so that we can forecast workforce needs. And I think that's the big missing piece for us now. We have data sources. We don't necessarily have the analysis capacity, and we don't necessarily have the support to make that a priority. So, and that goes on the federal level down. For the workforce, we'd also like to see a strategic plan. We can't do that strategic plan without the data in place. We'd like to see that strategic plan tied to a formal state health planning process. And I know there's been many people on the webinars that have identified a workforce strategic plan as a very important piece to this. And then the visibility of public health practice and careers. We're seeing a better defined pipeline into public health careers. There's really a lot going on in the national level to develop undergraduate programs, and we're seeing that here in Connecticut as well. We have a new one out at Eastern Connecticut State University, and the University of Connecticut just started an undergraduate public health course out at Storrs that will hopefully be brought into a program as well. And then there was a grant received by the University of Connecticut to work with the community college system to hold public health courses at the community colleges. So I think that's really important. I think that's going to address the second bullet there, connect the public health and the healthcare career pipeline. Because, again, we should really be talking about this on a continuum. And then the teacher and guidance counselor awareness at the middle and high school level. And I think there's an awful lot going on with that as well. CPHA is doing training for teachers on public health concepts and careers, and we've received a grant to do that, to hold another teacher training. And they've got a mentoring committee that is working on those issues with them, and so we're hoping to forward that as well. Continuing education training, there's a lot going on here too, I have to say. There's competency development, certification exams for the public health workforce. We are moving to that certification piece. Standards for training, and then a national learning management system for the public health workforce. And we are one of 28 states that participate in that. It's called Train Connecticut. But that's all geared at, toward the workforce, getting into that continuing education and training piece, which is really critical because once you're in public health, you need to have a commitment to lifelong learning because of those emerging health issues and the technology and everything that changes so rapidly. So those are some of the things that I think we need. It would be great to have those on the federal level coming down. In the absence of that, I hope we can talk about that at the state level and work with the healthcare side to kind of bring that continuum to one kind of pipeline there. So I'll end with that.
Great. Thank you. I will just pull up Jennifer's and start that up, and then Jennifer, you can start.
Thank you. Well, thank you for asking me to speak with you today. As Ellen said, I'm Jennifer Philippone. I'm the Chief of Practitioner Licensing and Investigations here at the Department of Public Health. In regulation, we do a lot of things, I think, that interplay with some of these health force issues. So if you can move to the first slide, or the next slide, I guess. So in the section that I manage, we regulate more than 55 different categories of licensed and certified health and health-related professions and have over 200,000 practitioners that we're responsible for. We manage the Physician Profile Program, the Connecticut Nurse Aid Registry. We investigate all of the health complaints that come in against any of the practitioners that are licensed and certified by our office. As well as complaints against individuals perhaps who don't have a license and are functioning in an area where they would require a license. And we are also responsible for the J-1 visa application review and approval process. If you can go to the next slide, please. Just to tie back to Kristen's presentation a little bit, she talked about the essential public health services and the core functions. And in particular, in health regulation, we work toward meeting the goals in 6 and 8 and enforcing laws and regulations that protect health and ensure safety and assuring competent public health and personal health care workforce. Through the establishment of uniform guidelines for licensure requirements, maintenance of competence and things like that, out in our enforcement efforts and our complaint investigations and such, the regulations really work toward helping us to achieve those goals. If you can go to the next slide, please. This is just a sampling of some of those 55 professions that I talked about and the number of licenses in each one of those areas. I just put that out there for you just to get a feel for some of the kinds of professions that we have. These are mostly the healthcare and health-related. We do have, anything from hairdressers and funeral directors and veterinarians and such that we also regulate out of our office. If you can go to the next slide. I think one of the things that Kristen wanted me to talk about was our e-license system and what's that about and how does that relate to some of these workforce issues. So back in July of last year, we've been working for many years on implementing an online license renewal system for our practitioners. It's now implemented for physicians, dentists, and nurses. We partnered with the state's Department of Consumer Protection on this initiative. We were really able to leverage the funding that we received to establish the new licensing system by partnering with DCP, and in fact we share the same licensing system with them. So for example, if you're an advanced practice registered nurse, and in our state you can prescribe, you also have to hold a controlled substance registration permit through DCP. So all of our records and our licensing information for the two agencies is now being housed together, which allows us to work more efficiently. We're trying to come up with ways for sharing data better and to make our data system much more robust statewide. In terms of the health practitioners that we license, over 8,000 practitioners have renewed online since July. and we're hoping to get the other health practitioners renewing online as soon as possible. One of the biggest benefits to the online renewal process is our ability to collect workforce data that's previously been unavailable. One of the real impetuses to getting us the money in order to implement our new data system was the attractiveness of being able to start to collect workforce data that we've never been able to collect before. So with the physicians, dentists, and nurses, the system was designed in a way that every time you renew your license, you're going to have to online, you're going to answer a series of questions ranging from what your current work status is in your profession, where you're practicing, are you retired from the profession, are you on a leave and you intend to come back to the profession, really trying to firm up some data regarding the age of our workforce. We don't currently have, for example, date of birth on every one of our licensees, so we're using the online renewal system to help us to be able to firm up that data and capture that data as well. And the goal would be at the end of the first year or so to be able to start looking at that data and our partners being able to, trend some information and such for us. Right now that survey is out there for physicians, and we're in the final stages of implementing it for dentists and nurses. And again, once additional health professions are able to renew online, our intention would be to extend that survey process to them as well. If you want to go to the next slide. The other piece that Kristen asked me to speak about was our piece in the J1 visa program. So the J1 waiver is a state and federal partnership that assists international medical graduates to practice in health professional shortage areas. There is a 3-year service obligation for them in order to maintain that visa status. And DPH's role is really threefold: facilitating the application and approval process, which happens through my office, as well as identifying placement opportunities and facilitating matching. And those two pieces Johanna is going to reference in her presentation. If you want to go to the next slide. In terms of the J1 visa program and how it's managed through our office, applications are accepted beginning October 1 of each year. In fiscal year 2009, we received and approved and sent out 24 applications. There are 30 slots that are available. To date this year, we've received 11 applications and 7 have been approved to date. We're now participating in what's called the Flex 5 option. Previously, the J1 visa program was available to physicians who were under contract to work in medically underserved areas. And then within the past few years, the federal government made some changes that 5 out of those 30 slots could be used for physicians who were going to provide care and services to patients who reside in medically underserved areas. But the location where they were practicing didn't necessarily have to be in an underserved area. The goal was still to get to the care to the right people, regardless of the practice location. And I think that that's, I think that was my last slide, so that's a good segue into Johanna's presentation.
Okay, let me pull that up, and we will start there. Johanna, you can start.
Thank you. Hi, I'm Joanna Davis. Mary Jane Mitchell is here with me also. I am the primary care officer for the state of Connecticut, and Mary Jane is the go-to person for the J1 visa for information on what positions are available, and she is sitting here too for questions if you have questions in the end. Next slide. First, I just wanted to talk about what a shortage designation is. In Connecticut, my role is to forward along information that is collected to HPSA to make designations, shortage designations. They're based on areas, populations, and facilities within identified that have identified shortage of healthcare professionals based on specific criteria. And I will get into the criteria in a minute. Next slide. The purpose of the designations is to identify the areas of greatest need so that limited resources can be prioritized and directed to the people in those areas. As you can see, there are two types of designations. There's the HPSA, which is the Health Professionals Shortage Area, which is what I'm working with more right now, and we'll get into what the criteria are for those. And then there's also the medically underserved areas or populations. And if we go on to the next slide, it'll show you some of the criteria that we look at when we're doing a designation. And this is a rough outline of some of the stuff that we look at. Total population, number of providers and total FTEs, percent of population at the 100% and 200% of poverty level, infant mortality, low birth weight, miles or time to the nearest source of non-designated care. We map the areas surrounding the area we're looking at to see what is accessible in those areas, and explaining what the barriers are for going to get care in those areas. With this, part of it's a weighted system. If you're high on one area, you could be low on another, so that if you have very high poverty, that'll give it a higher weight, and if you have extreme amount of underserved in one area, that you only have a few physicians that take Medicaid patients, all of these things are considered into the equation. Including, we are looking for dentists, we are looking at their age because the age of the dentist is increasing, and we are going to have an extreme shortage there soon. With the miles and minutes to nearest source of non-designated care, we consider the population. If it's a urban population and they're going to be taking buses to the doctors, we look at bus routes and time on bus route and how many changes they have to make to get there. So there's a lot of more layers underneath this that can be looked at. Next slide. In Connecticut, as of right now, there are primary care designations. There are 40 in Connecticut. There are 19 mental health and 37 dental. Those are the three categories of HPSAs that are available. And with each of those, we look at the clinician population for that specific area, and there are some different criteria that go into each of those, but a lot of the basic information is the same. These are all, in Connecticut, the way we look at areas is by census tract, unlike a lot of other states. When we send the information to HPSA, they either want it in a specific census tract or in a county, and we are very much restricted to submitting based on an electronic system that they have now called ASAPs. So when you're looking at Connecticut, keep in mind you're looking at census tract areas, not necessarily a city or a county or even an area. We look at specific individual census tracts. Currently, we have 17 MUAs and 12 MUPs. What you will see further on in the slides are the websites that you can go to look these specific areas up, so that you can go in, and if you want to see if you're in a HPSA designated area, you can type in an address. You can look up to see whether you're in one or not. the next slide. my role in the state, I am kind of like a filter or a funnel that I provide information from HPSA out to the public, and when when providers or clinicians want to get information from HPSA, they can contact me and I can forward their information back up to them. I am the person who has to submit the applications for the HPSA designations, and one of the things I'm trying to get out to people is how this can help the clinicians out there now. It is a requirement for any clinician to be in a HPSA designated area if they want to get the National Health Service Corps loan repayment or scholars. To get a scholar, you have to have a certain HPSA score, which is higher than just for the loan repayment. When I'm making a designation or making a recommendation for a designation to HPSA, I will be in contact with the providers that are interested, looking to hire scholars or get a loan repayment for their employees. And we can work back and forth with some specific information that's related to that site or that area, and we can incorporate that information into the application. Also, the J1 waiver program that needs to be for in a HPSA area or a shortage area. Also, physicians that are in HPSAs can get an increased rate of reimbursement on Medicare. So sometimes when we're contacting physicians to find out if they're seeing if they have a sliding scale fee or how could this help them, this is one of the things that we say they're eligible for if they're in a HPSA area. The next slide. Thank you. Just so you can get an idea of what Connecticut looks like as far as shortage areas goes, these are HPSAs by town, and you can see the little asterisk. As I said, we don't actually go by the town borders, we go by census tracts, but so often the town, for example, Hartford, just recently, the whole city of Hartford was designated as one area, and so on the map you'll see the city of Hartford, and it just happens to correspond exactly with how the census tracts for that shortage area are. But this can give you an idea of how it is in the areas where there's greatest poverty or where they're outliers. They're in more rural areas, so they don't have the access to the providers. Next slide. For the National Health Service Corps, it is a federally sponsored program that they have the scholarships where they can put the scholars out in the fields and shortage areas, and loan repayments for a variety of clinicians. I don't have the list of every type of clinician or provider who can get loan repayment. They have just readjusted that, and that list is available on the website. Their service obligation needs to be in a shortage area. Our role is to verify that sites are National Health Service Corps, that they match the criteria. We give technical assistance to the sites and to people who are calling with questions about different areas. We are the liaison for the sites to HPSA, and we will be doing site visits for compliance for these. The next slide. Just recently, with some of the ARA funds, we have, or HPSA has been able to expand their loan repayment schedule. It used to be just for 2 years for up to $50,000. They've expanded it, as you can see on the slide, for up to 7. With this, their objective is that they are trying to get both more people in the shortage areas and to keep them longer. Because what was happening was people would go in and only stay the 2 years in the shortage area and then leave. So here they're trying to keep them longer and recruit more. The next slide. Okay. As of right now, on the HPSA website, you'll see that there are posted 116 healthcare professional positions, 104 for loan repair placements, and 12 are for scholars. Anyone can access these websites and get the most up-to-date information that's available. Next slide. As far as the J1 visa program, the state and federal partnership that assists the international medical graduates to practice in shortage areas. There's a 3-year service obligation in the underserved areas. We facilitate the application approval process, identify placement opportunities, and facilitate the matching. Next slide. Since 1998, there have been 207 placements, 148 for primary care, 15 for psychiatry, and 44 for other. Next slide. These are some of the websites that I would encourage anyone to go into and look up information. There's a wealth of knowledge at these sites as far as if someone's interested in applying to get their area designated for HPSA, or if they are looking to be be a loan repair, or if they are a provider who's looking to get their site approved. The first one is the HPSA Find, which can tell you if you're in a HPSA area. It would refer you to me if you're looking to find out if you can get designated as a HPSA area. If you go to the next slide, what it does, you can select the state, select the county, and then you can say which area you want to look in, dental, mental, or primary. And this is actually this is as up-to-date as you can get for information on this for both the HPSAs. If you go to the next slide, this is for the MUAs. And once again, you can go in and look up specifically whatever area you want by county. If you go to the next slide, okay. This is the site to go to for if someone is looking for a vacancy, either for a loan repair or scholar. You can go in here and you can look up in Connecticut all of the vacancies that are available for a specific specialty and discipline. You can see when they're looking to hire. You can look it up by specific area. And the connections to all the requirements, the applications, everything is right at your fingertips here. So I recommend that anyone who's interested can go here. Another website that I had put up there was to the data warehouse, which if you go on to, the reason I don't have that one on here, thank you. The reason I don't have that one on here is they didn't reproduce very well in slides. But you can go in and look at a map that shows you a visual representation of what's going on in the state. And it's another site that you can go to go in and look at and play with the areas and see what's going on. I encourage anyone, if they have questions, to call me, or my address and phone number are on the first slide. If there are any questions that don't come up today, in the future, please call me. My job is to work with people out in the field. Thank you. To get services out to the people, to get the areas designated, and to see what we can do to get clinicians and providers staffed out there. Thank you.
Great. Thank you very much. David, did you want to ask a question? David?
Sorry, I had turned my mic off. Actually, a quick question about I think the Flex 5 program. How do you verify that people who aren't actually practicing in underserved areas are seeing populations that are underserved? How is that verified?
This is Jennifer.
Yes.
The hospital or other organization where the physician has contracted with for employment is actually required, is going to be required. We just started this. The regulations passed, I believe, back in November or December, and we haven't gotten our first applications yet. They would be due in April. The hospital needs to provide us with documentation to demonstrate that at least 30% of the clients the physician would see in their institution live or reside in a medically underserved area. So the onus is placed on the institution to provide us with that data.
Okay. All right. Thank you.
I wanted to ask about the designation of the shortage areas, because it sounds like that might be a way to get more resources, especially to areas where we're underserved. And I was surprised at how, when you said those are census tracts are fairly small. And just as a healthcare person in Connecticut, I'm sure there were a lot of places on that map where I know there are shortages. I have clients who are having trouble finding health care, but they weren't designated. So a community has to apply. We don't sort of do an automatic assessment of census tracts in the state. And I know that some communities have had to hire a consultant to do that. Is that a barrier?
I was going to say, I am actually new to the primary care office. It used to be that there was an outside consultant who did the applications that were for the shortage areas. Now I'm the person who submits the applications. HPSA has a new electronic system that all applications have to go through. So they have to come through me. But we are also, right now we are doing a reassessment. First, we're actually working with our list of providers that is in the electronic system and trying to get that up to date. There is a process where we can look at any given area and get it designated as an underserved area. We are not at that point yet. We have a new staff member starting tomorrow that's going to be full-time for the primary care office. to help us, push some of the previous applications that have come into us through. What I'd recommend is if anyone, provider or clinician, is interested in a specific area, if they call me or send me an email saying they're looking to get their area designated, then I can, once I have that request, I can move them into the queue and look at that area and see what we can do.
I guess I was thinking of it more, rather than putting the onus on providers, who in a medically underserved area, oftentimes Medicaid, we have a lot of trouble recruiting doctors to take Medicaid, because who's going to sign up to lose money?
Right.
And it just seems to me that this might be a way to sort of help in those areas, but I don't know that putting the onus on the busy providers is really going to work. And I'm thinking as a task force whether it would make sense for us to have a recommendation that we hire those consultants or we get new more staff so that we can look at some of those other areas in the state where there probably are, they would probably be designated underserved areas if we could just do the, push the application through. And the state could take the onus on of doing that. And I mean, if we could get 10% increases in Medicare for, providers in certain areas, that would be a very serious, even if there aren't any more, J-1 visa, applicants or anybody else, even from the National Health Service Corps, maybe we've got all we're going to get. But just getting more money into those, higher reimbursements into those areas would attract people. And I'm wondering if that's a recommendation. Do you think that would be a good recommendation from the task force, or is that there's something wrong with that?
I actually, I would say it's a good recommendation. Because the primary care office has been located in different places and different parts have gone to different areas, we are not up, fully functioning. However, I know there are, well, right now I have about 14 requests of applications that are backlogged, basically, that we're doing work on. But there are many, many more areas that could possibly be designated either as a shortage area or based on population, that there are many in the state, and it would only benefit the state to be able to look at the whole state to do that, yes.
Okay. Then I heard a yes. Good. I have a question for now I have to talk the rest of my task force into it. I have a question for Kristen. You talked about sort of, I mean, I was sort of daunted by all the different classifications of public health workers, and I know some of them, the training for all of them is very different. It's not like we could just say, more MPH schools, and we would get more of all these different, like a public health nurse, it needs a nursing degree. Is there any sort of sense of whether it's an educational problem? Is it the same problems you see in nursing, faculty shortages, clinical sites? How would we get more people to be able to build that workforce?
Well, I think we have a problem defining our workforce, number one, because it's so spread out. And having people understand how to get into a public health career. There's no straight arrow. There's no, you don't go into your nursing profession and come out with a public health nursing degree that I know of. So, a lot of it is, does have to do with that pipeline and building in that awareness of what is public health, what are public health concepts, and what are the public health careers, and how do I get from point A to point B. And I don't think anyone's figured that out. I think that's a big issue right now. I think they're working on it. I think the undergraduate programs at the right end of the pipeline, where people come out of high school and they can now go into, they think, well, I've heard about public health, maybe I'll go and get a public health degree. In my undergraduate, they're working on that, and then the pipeline moves into a master's degree. But behind that, I think that's really where we need to start putting some kind of emphasis and how we can connect a lot of the healthcare careers that can transition into public health and make those people aware of that option.
So it's more of building public health capacity in all the different educational streams, sort of.
Yeah, exactly.
Okay.
And that's what I think is so important about this community college system, making a public health. They've got a lot of the medical careers, associate to nursing degree programs. And if we build in a public health course in there, that's the start of it, you know, and really talking about public health and health care on a continuum, not separate educational systems, not separate, you know, it's all separated right now where it really needs to be linked in some way. And I'm not sure we've figured out what way that is, but I think we're generally talking about it and starting to move in that direction.
Okay, great. I don't know if anybody else has any questions. Nobody's...
Actually, I do have one last one, if you don't mind.
Yeah.
It actually has to do with the public health workforce. If I remember correctly from some of the slides, it seemed that particularly some of the FTE slides, it seemed that the workforce was fairly administratively heavy, and I'm not sure if that is sort of an accurate representation of the workforce, but I was wondering if that was primarily due to the fact that people migrate in that direction after they've already had a career doing something else, or if it was largely a function of, sort of people who've been doing it for a while, just sort of migrating upward in the public health system, and not enough people coming in behind them to backfill.
Are you talking about the technical and support staff line? In the state public health workforce? Ellen, just put that slide up. I just want to know where you're referencing the heavy administrative.
Well, it might be the top line.
Actually,
Leaders and
the top line, just sort of compared to the rest of it seemed a bit, I don't know, or maybe it's just my bias.
The leaders and administrators, what's counted in that category is everyone from the commissioner, deputy commissioner, all the directors, and all the public health service managers, so all the way down to the management level.
Okay.
And that actually doesn't include supervisors, so I didn't really think that was that large for an agency of 800 employees or so.
That's fine. I was just looking at that number compared to the number of nurses, and a bit more than half the number of nurses, and it just sort of struck me.
Yes, but I could see where that. The nurses are spread across the agency and work in different areas. I think we've had the public health and nursing capacity. That's always been an issue. Certainly, those are one of the key fields where we get anecdotal evidence and survey evidence that we have a shortage of nurses going into public health, wanting to work in public health careers. So that could be a function of that as well.
Thank you.
Well, great. Thank you very much. As I said, this will be up on our website as soon as I get my web person to do it. So thanks a lot. And we have another webinar on Monday, so I'm hoping everybody goes to register for that one as well.